Hello and a warm welcome, ladies and gentlemen, to this PCR webinar today, supported by Philipp. So, live from Paris, we today want to talk about lead management during tricuspid interventions. This is really a hot topic. So, my name is Philipp Nikolai. I'm the head of the Interventional AV Valve department at Bosch Health Campus in Stuttgart, and I'm pleased and honored to have two good friends and dear colleagues with me. To my left, Przemyslaw Mitkowski from Poznan in Poland, and on my right, Marcel from the University Hospital of Bonn. So before we start, I want to show you the learning objectives. So we want to understand and prevent the lead problem, which TR is lead-induced, which TR is lead-associated. We want to learn how to handling leads during T-TEER procedures. There are different techniques, and not at least, we want to understand the lead problem and treatment options before TTVR procedures. So what is jailing, what is removing, replacement options. And before we start, we also want to be very interactive. So you can ask us questions via the poll and via the chat system, and we'll be glad if you attend with us together. If you send us some questions, and then we can discuss it directly here together with you. Okay, before we start, some short slides about definitions. So what is a lead-associated TR? That means that we have a lead into the valve, but that the lead doesn't affect TTR. Against the lead-related TR. That lead-related TR means that the lead is the origin of the tricuspid regurgitation. And Przemyslaw will show some data afterwards, how often this will happen in all the patients who have a lead in the valve. Okay, but do we have some mechanisms of lead interaction? So what is really rare is the leaflet perforation, and what is also rare is a subvalvular damage and entanglement, but what is very often is the leaflet impingement. So that means that the lead presses on one leaflet and so opens the valve and then sets the origin for the tricuspid regurgitation. So we discussed this, or we showed this, and also we have some pacing-related problems. If we have this RV pacing, that the right ventricle or the left ventricle will become in another shape, so that we can get tricuspid regurgitation out of that. We have a leaflet subvalvular fibrosis that we have also keep in mind, and a hot topic is the lead-induced endocarditis. Yeah, and so we have also considered this and talk about this. Yeah. Risk factors for lead-induced TR is the lead number, how many leads are induced, the apical lead placement that brings us to another shaped tricuspid regurgitation, the lead placement technique, absolutely, the angle and the position of the leaflet. So Przemyslaw will show also some data about that. And if we have a pre-existing tricuspid regurgitation, and I mentioned it, we have also to talk about lead infection risk. So what can we do if we have a system infection? So this was the introduction. I think we can go to a first case. Again, be interactive, ask us some questions. We will directly answer the questions after each presentation. And yeah, I'm glad to have you here, Marcel. And I think you start with your first presentation. The stage is yours.
Yes, thank you, Philipp, for the introduction, and thank you for having me here. It's a pleasure and honor as well from my side. Marcel from Bonn, and here are my disclosures. And before I show you 3 cases, I want to start with a poll, because I want to know how you feel about leads in TTVR. We have 3 answers prepared. So A, it's no challenge for you, or B, you have to be careful, but it's possible in most cases, or C, if the leads are in the way, I will give it a miss, so I will stop the procedure or never begin. So what is your answer to this question? I think we will do the poll at the end of my presentation, and then we will discuss about the results. So I start now with my cases, and I have brought a normal case to you. It's this 86 years old female patient, and she has AFib, and she has a pacemaker in place due to a AV block second degree, and it was upgraded to a CRT-P system. So the left ventricular function is quite okay. The videos are not moving, but I can tell you that the TR is massive. And the tricuspid annulus is quite big. And as well, you see it on the right bottom side, that the gap in the central position is not small. So it is not a very easy tricuspid case. And I want to show you how we started. We went for a triclip procedure. And at first we directly got problems. As you see on the left-hand image, we got entangled with the RV lead. But we were lucky. It was just easy by clocking the system to get rid of the RV lead, and so we could do our work again. But so one step is be careful when you cross the leads. And this is our first clip position. You see it on the left-hand side of the slide, that we place the clip transgastric. We love to place the clip transgastric in the anteroseptal commissure. And I think it's important to start there, because when you start there, you can work over to the posterior side, and then you have better visibility, especially in the transgastric view. And on the upper image, you see the clip system in fluoroscopy, and you can imagine that the RV lead is freely floating, so there's no entanglement between the leads, and we see it also in echo. Then we headed over to the second clip device, because you see that the TR was not gone. And you see that the second was placed just a little bit posterior of the first one. It is an XTW clip. So, and we were very happy. And you see in the upper fluoroscopy that the RV lead is 2 centimeters away and has no interaction with our system. So quite better result, but not yet perfect. You see still a central TR, and so we had it for a third system. We placed it in the posteroseptal, or in the central position. You can see it on the right upper video. It's just in the middle. We call it sometimes the eagle, coming from septal to lateral. And so we got a good result and had just a residual TR. I would call it 1 to 2. In the middle of the valve, of the 4-leaflet valve, and we had almost no gradient. And this is the anatomic result on the left-hand side, and the discharge echo on the right-hand side. So I think it's a very good result in this difficult case, and we had no problems with the lead at all. So,
yeah. Marcel, thank you. I think we stop here for a discussion of the first case. Very beautiful, really good, challenging thing. Is it very common to entangle with the triclip or the Pascal system on the tricuspid side in the lead?
Yeah, of course, there are sometimes more in the way, sometimes not, especially if you have more than one RV lead. So it can happen, and you have to be careful. I think especially fluoroscopy helps to get along. Yeah. But usually it's okay, especially when it's on the posterior side.
Yes, absolutely. So it is very interesting to bring the lead to the more posterior side, and also interesting that we end up with a great or a light to moderate tricuspid regurgitation. And it's also interesting to see that the tricuspid regurgitation, can you please start this slide again, that we see the tricuspid regurgitation doesn't come from the lead side, it comes directly from the central side, so that we can also, I think, say this is a lead-related TR, that's not a lead-induced TR. But yeah, to be honest, we want to be perfect, we want to not to be good. This is a good result, yeah. Did you thought about TTVR, so evoke, for example, or cardiovalve, for example, for these patients?
Yeah, very good question. We thought about it because it was a 4-leaflet valve and it was a somehow central TR. So in these cases, of course, clipping cannot clip everything to 0. So we thought about it, but the annulus was too large, so we weren't able to take the common prostheses which are on the market. So we decided to try it with a clip, and so I'm happy with the result because for this age, 86 years old, mild to moderate TR. So, and we didn't harm anything. The lead is in place, so it was good.
Absolutely, yeah, I fully agree. One question to Przemyslaw on this case: is it? Do you think it is possible to maybe in the case of a lead system infection, is it possible to remove the lead in this case?
I think that in patient with implanted ventricular lead, right ventricular lead, the approach with edge-to-edge repair is the best option from the point of view of device specialist. Because if you are a little bit careful, you can avoid any problem and entanglement of the lead with the device. Also, we can remove it. So I think it is when it is not attached to the leaflet or subvalvular apparatus, it could be quite safe, effective, and simple. Nevertheless, even in any other circumstances, it is fruitful because we are going over the lead. So when there is no connection between the lead and device, it's not a problem. Moreover, you know, we have here probably the lower area of the tricuspid orifice. So if it is not infection, but for instance, lead malfunction, I am also in favor of removing the lead. We can go inside the right ventricle with a guide wire through the sheet we use for the lead removal. And afterwards, we can go forward with, for instance, conduction system pacing sheets to even offer better pacing for this woman.
Okay, and the last, maybe challenging question, if we have to remove the lead, what would you do the next step? Leadless pacemaker or conduct or
you know, in general, when we have any procedure over the tricuspid valve, mainly surgical, but probably also transcutaneous, we try to avoid any device which is crossing the tricuspid valve because it could make faster the degeneration of the valve itself or any other artificial material which is here placed. So I would prefer a leadless pacemaker. We use for such an approach a jugular access when the crossing the tricuspid valve is much easier. Sometimes we'll need arteriography or ventriculography to find exact way where we have the big distance, I mean big area of the part of the orifice, and probably sometimes transesophageal echo would be also beneficial.
Okay, perfect. Thank you so much. So I look for my iPad. So no questions at the moment. Again, you can ask some questions. And then I think time is running. We go to the next case of Marcel.
Yeah, I have a second case, and it's a different scenario. It's a replacement scenario, and a lead is not a contraindication for a replacement. And in this case, we have also a patient who is above 75 years old and has a torrential central TR. And so we decided for replacement. Even if he has this CRT system in place and this RV lead, which is heading from posterior atrial wall and is crossing the tricuspid valve in the plane of the valve and going to the right ventricular outflow tract. You can see it on the right bottom image in the CT image and the computer tomography. And in this case, we didn't see it before, but we had the problem to get all steering maneuvers done with the evoke prosthesis. And that was the case that we got into the right ventricle and couldn't maneuver properly. And the problem was that the lead was like a hammock beneath the evoke prosthesis, and prevented us from coming below the leaflets in the anterior side and the lateral side. You can see it the right-hand side of the left moving image and in the right side of the four-chamber view, that we couldn't go beneath, and we tried different maneuvers to get alongside, but there was no option. And I highlighted the lead curves in red. You can imagine that we couldn't get deeper, and the probe, the lead was just in the middle, so we couldn't bring it lateral or septal, and that was the case that we have to bring the prosthesis out in the right atrium, and then go for conversion on the table, and the patient got a tricuspid valve replacement. This is a result 1 month later in the right bottom image, transthoracic echo. It was a very good result, but of course we learned our lessons that this lead, if they are under tension and they go just across the valve, that they cause problems, and we couldn't get out again. So this special case, which was unsuccessful, but I think it's important also to show those cases.
Absolutely, absolutely. Thank you, Marcel, for the second case. I think it also that we have also show our problems and our unsuccessful cases. I had a nearly similar case, and we try to bring the safari wire to the other side of the lead. Then it may be possible, yeah. But this is very hard in some cases. You know it, I think so. Yeah, to steer the safari wire exactly at the same position. In this case, the lead comes from posterior and goes to anterior. I think there is no chance to bring the safari wire to another placement and then to implant the valve. What do you think about trick valve in these cases for the future? So the bicable valve system that doesn't affect directly the tricuspid valve, so that's a bicable approach. Yeah, so the heterotopic valve. What do you think about these cases?
Yeah, when we have known this result, of course, then bicable implantation like trick valve would be the best option. I think there was no option for a TEER device, so we went for a replacement device. But of course, we somehow underestimated the problems of the probe. And if you once get into the ventricle, you cannot come out properly. You cannot resheath the evoke prosthesis. And so afterwards, a replacement, a heterotopic replacement would be the better option. But somehow the operation was quite good as well. So the patient as well. But of course, it was not our plan.
But I am strongly against placing anything in superior vena cava like a stent, because we have here 3 leads. The likelihood of any complication in the future is quite high. And in general, in our everyday practice, we would like to make life easier. So it's an excellent case. I would recommend here to remove this right ventricular lead, as the position is not very good, I would say. Afterwards, perform any procedure or even implant the leadless pacemaker, even as a bridge therapy, because it is CRTP device, so probably patients suffer from heart failure. And afterwards, after healing the tricuspid valve, when we still have symptoms of heart failure, we can reintroduce the CRTP. So even sometimes, leadless pacemaker could serve as a bridge therapy.
Mm-hmm. Very good comment. So you fear any jailing of the leads, so in your hospital. But what about, yes, now we have, for example, 85-year-old female patient with a 20-year successful implanted pacemaker, and so the conduction system is 20 years old, and now we got a really, so we know that it takes time, from the origin of the TR to the decompensation, and now the patient decompensates after 15 or 20 years. You have a lead related or maybe also a lead-induced TR, 20-year-old implanted system. How would you estimate the risk
May I ask
of
for another question? You know, it's a difficult decision finally. We have to introduce patient and probably his or her family. Because, you know, when we have a system lasted for over 20 years, the likelihood of malfunction is very high. When we perform any jailing, probably part of the insulation is broken.
Okay.
So when we place anything, we just create the huge malfunction of the lead. Of course, we can reintroduce the lead when we find something wrong through the stand of this valve or anything. But you know, we also work on the re-establish the patency of the veins in some patients with superior vena cava syndrome. So we try to avoid anything inside the stent, because when you place any artificial body, the likelihood of restenosis is very, very high. So we start with this procedure with implantation of leadless pacemaker. Afterwards, we remove the lead, preserve guide wires inside the vein circulation, and ask our vascular surgeon to regain the access and the flow through the veins.
Okay, thank you, Przemyslaw. So I have a question from the auditorium, very nice. Though rarely happened, are there any factors or indicators could predict lead dysfunction or PVL after TTVR with RV lead in place? So,
Very good and difficult question.
absolutely.
I think we had never problems after placing a TTVR and afterwards the function of the RV lead was depressed, and we did about 60 or 70 TTVR replacements. But so I don't know the predictors, of course, but I think the more leads you have, the more problems you get when you go for a replacement. I think this is, you can say it.
There are several, I think, factors. First of all is the long dwell time, because, you know, the lead is struggling every day 100,000 of times. So, you know, for instance, one can expect after 10 years the malfunction of 20% of ICD leads. In pacemakers, probably it is a little bit lower, as we have very good technology nowadays, and the leads are not so sophisticated like ICD leads, and also diameter is very low. But, you know, one can expect mainly insulation problems. And afterwards you have the interferential. So you have noises on the lead, which is not working properly, and also cause asystole because of these artificial signals. So, of course, we have to take into consideration the mode of implantation, the type of the lead, the likelihood. We can observe on the company's website the reports of lead behavior. So we have long-lasting behavior over 10 years. Vast majority of these, of course, without such a procedure, the likelihood of malfunction is below 5%. But in some, we can observe even 20%. So we have to be very careful. I am strongly against jailing the lead. We have a lot of possibilities to remove the lead and offer patient good pacing mode afterwards.
Okay, so you like the TTVR, you like the T-TEER procedure more, yeah, in these late cases.
More familiar with, so
more familiar with. Okay, so one question from the auditorium. So would you consider lead extraction followed by TTVR by Evoke, maybe, or cardiovalve in the same procedure if both specialists are available in the hospital? We never did this. In the same procedure. You have experience with that?
I am strongly in favor of this, because, you know, for the patient is the only one procedure. We have a very good experienced team in any complication, because one can expect during, for instance, reed removal, the tears in the superior vena cava, subclavian vein, or in the heart. So we have a team who could fix the problem. So my dream is to work in such a company because we can offer the best treatment and the best quality and less complication.
Okay, so you would go for leadless pacemaker first, then removing the lead,
yes.
Then go for TTVR.
Yes.
So this is your point. So one question for me: did you ever, if we have a lead in place and we see that the lead is entangled with the leaflet, yeah, and after 1 year we see a high-grade tricuspid regurgitation. Patient is not suffering under symptoms, but we see a high-grade tricuspid regurgitation after 1 year. Would you retract the lead? What would you do? Would you do a follow-up of, or would you go directly for T-TEER?
I wish it not appear within the first 3 months, because during this time the removal of the lead is quite simply just traction, and we can proceed. There is no so much adhesions between the lead and the leaflet, so it is the best way to control the patient within few months after the implantation. Nevertheless, when we have lead-dependent tricuspid regurgitation, my general view is that during lead extraction, when we have adhesions to the leaflets or the subvalvular apparatus, we cannot improve tricuspid regurgitation. So, if there is no plan for any procedure for tricuspid regurgitation, it's better to leave leads in place. But when it is symptomatic or could be symptomatic in the near future, and it is a team approach, and we discuss, and probably the best way is to fix the tricuspid regurgitation in this patient. I am really in favor of removing the lead, extracting the lead, but there is one very important condition. There is a plan for any procedure on tricuspid valve.
Okay, and short answer, if the lead is 5 years implanted, then you have normally, from my experience, you have a connection between the lead and the leaflets. So this is, I think, the most common case. What do you think, Marcel? That the patient has a tricuspid regurgitation, we don't follow up him by echo, yeah, the electrophysiologist or the pacemaker specialist follow him up, and then we see after 5 years, we see the patient suffers under high-grade tricuspid regurgitation, lead-induced tricuspid regurgitation, and then I think we have a connection between the lead and the leaflets.
You know, it is very important to be as gentle as possible, because we have two forces. One, pulling force for the lead, we put inside the locking stylet, and the second one is pushing force with any cutting device. So it could be polypropylene sheets or tip-threatened sheets or laser sheets, and we have to be very careful. Less pulling, more pushing, especially at the level of the valve, because sometimes we can completely destroy the valve and there will be no possibility to introduce any transcutaneous technique to solve the problem.
Okay. Thank you. So, Marcel, I think you have a third case. Time is running.
Yes.
Marcel, stage is yours
I have a third
again.
case, and now the topic is prepare your leads, because the patient has two problems. He's 67 years old, has a massive functional TR, and he has an indication for ICD implantation because he has a severely reduced left ventricular ejection fraction with 25% due to coronary vessel disease. And so we had two problems, what we wanted to solve. And so we went to this procedure that we first try to place the leads properly. And I showed you on the next slide. First, it's about their anatomic conditions. So it's the TR is huge, and you see it on the right upper image that there is a big central gap which goes into the anteroseptal and the posteroseptal commissure. So huge TR. And we have, of course, no lead in place, but we want a lead, and it should be an ICD lead. And so we made the ICD implantation, lead implantation under TOE. So you can see here different lead placement maneuvers. On the left upper image, you see the lead going just into the middle of the valve, to the middle of the right ventricle. In the moving image just right beside, you see the lead going to the anterior side. And on the right-hand video, you see it more upper, more posterior, but not straight posterior. And you see it on fluoroscopy as well. And so by this, we try to find the best position of the ICD lead. And you see here, the last moving image, there is our perfect position. You see it up in the fluoroscopy and down in the TOE transgastric view. You see that the lead is in the upper part, so very posterior, posteroseptal. And we, of course, did the assessment with color again to see if the massive TR gets worse or not. And so we got the best position, postroceptal, and this was not then lead-induced TR, it was just beside the severe TR. So we were happy with this implantation. And then on the next day, we went to the tricuspid TEER procedure. I want to show it here. We showed it as a live case, and you see a Pascal implantation. It's time-lapse, so it's very fast. First position was, again, transgastric and anteroseptal, and you see how nicely the leaflets come together with the first Pascal system, and it was still a central TR, as you can see here in the image, and we placed a second device just beside it. You can see it in the next second. We tried to get rid of the leads. You see it right up in the fluoroscopy. And then we placed the system just beside the first Pascal. You see it in the left bottom moving image. And there you see that the TR got reduced to mild, perhaps moderate, mild to moderate, but we come from a massive TR with almost no gradient. It's about 1 to 3 millimeter of mercury. And so we got a nice result in this special case where we had two problems. First, we placed the lead postroceptal, and on the next day, we placed 2 Pascal systems in the anteroceptal commissure with a really nice result, and even anatomically, but also in color Doppler. And later on, you see their 3D images. There you can nicely see that it's a good position of the TEER device. So this was my last case. Here you see the 3D, so nice position and good result in 3D color as well. So this was my last case. So I want to give you take home, prepare your leads when possible. So as you have seen in the last case. Second, the posterior, the lead, the better for us to treat by a TEER procedure and as well a replacement procedure. And fluoroscopy is mandatory to get around leads, and TOE helps to see if your device or your lead is septal or lateral. And the last is you can push leads during T-TEER posterior or central. It's possible, but to push the lead anterior is very difficult. And you should not jail it. Otherwise, your pacing specialist will be not easy with you. Thank you very much.
Okay. Thank you, Marcel. Great presentation. Thank you so much. I have 2 questions. So, is it common in your institution that in some cases you have the TOE during implantation of a lead, during pacemaker implantation or ICD implantation?
Not, unfortunately not, but probably from the patient point of view is quite good, as it is a shorter procedure without, general anesthesia and so on. Nevertheless, probably in the future, why not to use intracardiac echo? Probably the benefit could be comparable, less stressful for the patient. I don't know, probably the price of the procedure became higher and higher. So no. Only for a few months we have our own echo in our EP lab. So
we do it not in every case. We do it in special cases like this, where we want to not make the TRs more severe than before. And I think in this case it was quite good. But of course, not in every case. We do 3 till 4 pacemakers a day, but we should look after it.
Okay. So another question, and then a question from the auditorium. How is it in Poland? Do you follow up the patients after pacemaker implantations by echo?
Not very frequently. When we have no sign or symptom or deterioration, not. But sometimes, echo could be quite effective and beneficial. For instance, when you program AV delay in patient with CRT. So sometimes when you can observe deterioration or patient talk about the symptoms which are new. Of course, echo is one of the basic examination.
Okay. In Bonn, I think not regularly.
Yeah, we try to follow up the patients, of course, especially after and before tricuspid regurg situations. So, but not every pacemaker.
Okay.
Yeah, to be honest.
There is one short question: how to manage when in need for pacemaker implantation after T-TEER or after TTVR? Przemyslaw, short answer after T-TEER.
In general, it is possible, of course, but sometimes the ostium of the tricuspid valve could be narrow, could be several ostiums, so it is not a very easy procedure. Of course, we need some multiplane C-arm and also inject contrast sometimes. Use probably catheter to cross the tricuspid valve, or even use the pictile catheter to cross the valve, and afterwards we can use any delivery catheter for instance, for CSP. Also, it is possible to implant the leadless pacemaker. In this case, we prefer the jugular axis as a curve between the superior vena cava and tricuspid valve, and also right ventricle is much more suitable for difficult cases.
Okay, Marcel, your institution?
Yeah, we use it from case to case.
From case to case.
Yeah.
Okay. At this time, we close the poll. We want to have in 1 minute to look at the poll. So time is running. So we talk about, we have a big discussion also about treatment options with lead-associated TR, and we see that T-TEER procedure is the best thing that we have. And we showed, Marcel showed that also the T-TEER procedure is in this lead-associated TR in the most times really good. So bring the lead to one edge, as you showed it, or sometimes to jail the lead. That's not jailing like in the TTVR procedures, like Evoke or something else. It's between two clips, and so I think you do it also sometimes. Yeah. If the lead is in the middle, if this lead associated and not lead related.
Yes, and I think we can bring them together by two clips, like a sandwich, but I think the force should be not too much. Otherwise, it could be damaged, I can assume.
Yeah, it's much more easier if we have a lead-related TR, then we have to call the surgeon. Yeah, that's always a good option in these cases. And also consider the TTVR, and if it's not eligible for TTVR, then we can go for a complex TEER procedure with not the best outcome, or in very selected patients also the bicable valve, or removing the lead followed by a TTVR procedure. So now let's have a short look at the poll. So we have the questions and 16 votes. So I have to look. Oh, it's interesting. So the first answer is it's not challenging for me. 6%. Yeah. Okay. Would you like to work with us together? Because I think we find it challenging as the most. Colleagues here, 88% is answer B. Yeah, you have to be careful, but it's possible in the most cases. And also 6%, if the leads are in the way, I give it a miss. Yeah, I think that's also not in every case a good thing. But now let's hand over to Przemyslaw, because he has some experience with lead movement, lead replacement, and
lead management, I would say, because it started with the implantation procedure. Nevertheless, one can expect this because, probably the case with tricuspid regurgitation and lead inside is not very good for the first cases. But afterwards, when you gain some experience with the treatment of tricuspid valve regurgitation, it probably could be quite common.
Okay.
So let me start with the first case. It is a horrible case of a 37-age woman who was implanted at this age with DDD pacemaker because of second-degree IV block. Afterwards, reposition of the lead because of dislocation. After 6 weeks, pocket infection. Finally, all leads were removed and the VVI pacemaker was placed on the right side. Unfortunately, a few years later, she got the severe tricuspid regurgitation, and I don't know why could happen this. she got the mechanic prosthesis of the tricuspid valve with jailing the lead. Afterwards admitted for the upgrade to DDD device. It was successful. Reimplantation of right atrial lead 2 years later, and reimplantation because of battery depletion at the age of 57. And just after this reimplantation, patient suffered from pocket pain. What to do? I strongly discourage her from any procedure, as we know that just after former procedures, the likelihood of pocket infection is quite high, and in this case, we have no possibility to remove the lead using transcutaneous tools. So it could be sent to surgery. I am afraid surgeons will not be so happy to do anything. But she insists on this. She works as a fitness trainer. So finally, we decide to perform the pocketoplasty and also use the antibiotic envelope, and outcome was very good. But I would like to underline that the situation in which we have jailing lead is sometimes a situation in which we produce problems for the future. We have excellent 2 documents related to jailing leads. There are some chapters in the recently published statement from the numerous EP societies, leading by Heart Rate Society from the United States, and also document published by European group leading by Jean-Claude De Haro last year related to patient with implanted right ventricular lead and necessity to perform any transcatheter tricuspid valve intervention. I strongly recommend these 2 documents, and there are a lot of knowledge related to this situation. Of course, I would like to object that the vast majority of tricuspid regurgitation are caused by leads. No, only 10 to 15% of cases are produced by the lead, whereas 5% is a primary disease of the valve, and 80% it is secondary to any other heart condition. Of course, we are talking a lot about the mechanism, about the route we introduce the lead. Sometimes, you know, we are completely blind. Where is the lead? Of course, there are some suggestions to proceed through the tricuspid valve as a loop of the lead for pacing lead, which are very gentle. I am probably in favor of this approach. Nevertheless, sometimes could be more difficult. Nevertheless, for ICD, I am strongly against, because, you know, the coil is very stiff. When we change the shape of the coil, probably it would be very difficult to implant in the proper place. More or less, this implantation of the lead is very good in terms of the low threshold for ventricular arrhythmia termination, so it is in the lower part of the septum. Nevertheless, I would suggest some other solutions I will show in a minute. So the prevalence of tricuspid regurgitation following CID is between 7 and 45%. This of grade of 2 or more, 10 to 38%. And of course, we have to evaluate it in details, because sometimes, in some cases, the tricuspid regurgitation should be present before the implantation, or almost the same level as after implantation. So what is the mechanism? First, implantation related. So during implantation, we can preserve the function of tricuspid valve. We have to be very careful, but sometimes anatomical conditions are so complicated that we try to complete the procedure, because after 1 hour, there is no motivation to preserve tricuspid valve, to tell the truth. Pacing related, because also we can observe development of tricuspid regurgitation when we have even leadless pacemaker implanted to the right ventricle, some device related mechanisms related to programming of the device. So what are the mechanisms of tricuspid regurgitation related to device implantation? One of the most important is perforation or laceration of the valve, entanglement of the valve, impingement on the leaflet is, I think, quite common, especially when we place the lead in the outflow tract, and also some conditions related to hemodynamics of the heart after the implantation of the pacemaker or ICD. On this picture, you have summarized some proposed underlying causes of tricuspid regurgitation. We have no time today to discuss this in details, but as you can see, sometimes there is only one factor we can show as a leading cause. Sometimes there are several factors. In this American document, I would say multi-scientific society document, there is one clinical scenario related to our cases today. So we have 82 years old woman. So, we will face this problem in a bigger amount in the future as longevity increases, likelihood of having pacemaker in octogenarians is quite high, and also tricuspid regurgitation. Unfortunately, because of numerous comorbidities, cardiac surgery is impossible or related to high risk to the patient. So what are the management strategies? So transcatheter valve replacement, of course. The only option in this woman, she is dependent on the pacing, so we try to avoid the jailed lead because in any case of complication and malfunction of the lead, she could just die within tens of seconds. And she was scheduled for elective lead extraction and the placement of leadless pacemaker. So we have no jailing leads. We have very nice space for any procedure related to tricuspid valves. There is nothing which can protect us from almost any device. And in some patients, right ventricular lead is not essential because they suffer from sick sinus syndrome. So sometimes atrial lead could be enough. As we are going for any tricuspid procedure, you can find here that surgical tricuspid valve replacement causes high likelihood of pacemaker necessity from 19 to 35%. When we have transcatheter valve, it is much lower rate of pacing indication in transcatheter edge to edge, which is preferred for electrophysiologists. The likelihood is very, very low. Of course, we have numerous conditions. Much of them were mentioned already today. But what I'm afraid of, especially in older leads, that we have somehow destroyed insulation. When we put any pressure over the insulation, it could break, and we'll got some noises on the lead, and the pacing properties of the lead cannot be supported longer. And what is even more important, infection in any bacteremia, class 2A indication for lead removal, or any vegetation of the lead, class 1 indication for removal, it would be highly difficult to remove. It would need very experienced team, a lot of tools, and the final outcome is not predictable. Here we have one of the latest papers on the likelihood of lead malfunction over time of 12 months. It is only less than 6%, but for this 6%, it could be a very important condition. In other papers, they report even up to 31% of significant lead dysfunction. If this lead is jailed, because it is one of the most important mechanisms of the lead malfunction, we can go into trouble. Of course, we can implant the lead through any valve, which is introduced transcutaneously, or TEER procedure. Nevertheless, in case of infection, still we have this lead, which is malfunctioning. We have broken insulation, which gives a lot of possibility to be contaminated with the bacteria and develop lead-dependent endocarditis. So, returning to our document from this year, in general, when the lead is crossing the tricuspid valve and we plan TTVR, lead removal is recommended to avoid entrapment of the lead and facilitate TTVR procedure. And it is class 1 recommendation, so I am in favor of such an approach. It is also some another clinical condition in which transcutaneous lead extraction should be considered. First, patient dependency, because in any case of lead dysfunction, patient could die. Also, ICD with previous therapy, as malfunction of the lead could lead to inappropriate shocks or insufficient shock to terminate arrhythmia. But also, when we have multiple leads crossing tricuspid valve, sometimes we have a loop. So we have an atrial lead which crosses tricuspid valve and could also produce tricuspid regurgitation. Previous infection, very important factor, because the likelihood of the next infection is relatively high and highly tension, so low slack and or leaflet impingement in case of direct annuloplasty. So we have to balance risk of extraction procedure and the risk of infection. Even less pronounced lead malfunction, because we can introduce another lead. And here we have a case published 2 years ago. It was really very, very difficult to remove this lead. They used tandem approach, so the second loop was introduced from the femoral vein. They used laser, and finally, they even does not cross this valve, but the lead was released from the endocardium. It was located in the middle septum, so it was quite good condition for lead removal. And here you have another pictures from this paper. So what is the potential risk of JADE lead? Significant paravalvular leak when we, of course, perform the lead extraction, prosthesis of vegetation embolization, damage of tricuspid annulus. From wider caliber of extraction sheets, you can imagine that the lowest diameter of laser is 14 French. We have also 16 French. We have 11, 13 French of other devices, so it is quite big hole, and snapping of embedded leads. So what we can offer? We have a lot of new technologies which are available. So his bundle pacing, but without crossing tricuspid valve from above the valve, leadless pacing, coronary sinus, lead implant or lead across the valve, and here you have some examples. So here you have the leadless pacemaker going through the, it is the ring, Duran ring, and the implantation was quite nice. Not very easy, but rather easy. And of course, in such a case, when I proceed today, I will use the jugular access as we have a much better angulation. Here we have a patient, of course, without tricuspid repair, but the patient with problems with right ventricle. So we implant ICD leads to the coronary sinus, pacing leads to the coronary vein, and patient got several appropriate shocks, and these shocks were effective. Another examples, we have completely out of vasculature ICDs, it is subcutaneous ICDs, when patient does not need pacing or does not need CRT therapy. We can offer such a system, also extravascular, which offer also anti-tachycardia pacing, and finally, as a bridge therapy, wearable cardioverter defibrillator. We are expecting the new solution in which the subcutaneous ICD will be connected to leadless pacemaker and can offer both pacing and also delivery of anti-tachycardia pacing. Finally, we have just approved the device to pace the left ventricle from the endocardium. The transmission of the energy is through echocardiographic waves. We have an ultrasound generator placed in the intercostal space and battery placed under the skin, and we can offer a synchronized pacing to any pulse in the heart, so it could be synchronized, for instance, with any leadless pacemaker. And finally, a published case with a lead which crossing the valve, which is also possible. I think that J-link is the worst solution, but of course, in some cases, when patient relative risk of lead removal, lead extraction is very high, or patient disagree to undergo such a procedure, we can implant the valve. Of course, we have to explain to the patient that in terms of infection, we've got a problem, and the solution probably will not be easy and probably not final one. And I am really in favor of multidisciplinary team approach. So sometimes we have the labs on the same level, so we have to talk each other, and I think that we both can offer ourselves the best solution for the patient. Thank you.
Yeah. Thank you, Przemyslaw. It was a great presentation. Also, the colleague who removed the lead in this jailed lead in the surgical valve was, I think he was in luck. Have you experience with removing the lead after some TTVR cases?
Fortunately not. Of course.
Not unfortunately, because we have experience. It's not easy. It's nearly not possible.
Sometimes you can only break the lead, and it is, I think, that one of the worst final points of this procedure, because you have open wires, open insulation. Nevertheless, of course, when you have a very good team approach, so you have invasive cardiologist, cardiovascular surgeon on place, you can do probably everything. In any case, you can intervene within minutes, which is really crucial for the outcome of the patient and survival of the patient.
Okay. So, Marcel, in your institution, University of Bonn, do you also discuss every patient in terms of endocarditis for removing the lead before TTVR procedures? I know you do a lot of TTVR procedures with different systems.
So if there's just a normal lead in place and the patient risk is not quite high, we would not discuss it prior to the procedure. We would do it. At least I know the risk for TTVR, so replacement, and endocarditis is higher than after TEER procedures, of course. But I don't think that the risk is due to the leads which are in place or to the data. We know it's not shown yet.
Okay,
yeah.
Absolutely. You talk about lead removement. How is the risk of a lead removement? What do you think about?
We have very nice registry. It is called Electra, published a few years ago. It was multi-center European registry. And in experience center, but experience was defined as a 30 or more procedures, extraction procedures a year. The likelihood of death during this procedure was extremely low, around 0.3%. Okay. Severe complication rate around 1.5 to 2%, so not so much. There is a conference which name is Expect the Unexpected. So we are discussing what could happen and how to protect the patient. And I think it is very important. We have to talk to the patient, have to talk each other, and offer patient the best treatment and safe treatment. It is very important because, as you said, when we have fragile patient, 95 years old, probably the likelihood of consequences of lead damage or infection are less severe than removal of the lead extraction.
Okay, so I think we learned TTVR is not always the option. And I look for the poll and I look for the audience. There is no question left. We have 1 minute left. So I think we can conclude that we have a large discussion about this hot topic. We have some open questions. We need more data, as always. Yeah, and I think we have to be in awareness that sometimes we not go straight forward to the TTVR, so that we have to think more about lead removement before, and also that if T-TEER is possible, then we have open space for everything after this. Okay.
But I would like to underline one thing. Even if patients have a lead, it is not the condition. We don't offer the patient the treatment with the valve. Yes, it is it is mandatory to offer the treatment and try to do our best for the patient.
Yeah, and in a big discussion, and we have to need the whole toolbox for every patient, so individualized medicine. Okay, so the time is almost off. I have to thank you, my dear colleagues, Przemyslaw and Marcel. It was really a great pleasure to work with you together. We have to thank our supporter Philipp, and of course we have to thank PCR and the whole team, the entire team behind the scene, so especially Alexia and the team. And not the last, we want to thank you for attending, for the interaction. And we wish you good procedures. We wish you good decisions, good discussions for your patients. And from Paris to Europe, we say goodbye, au revoir und auf Wiedersehen.